Welcome back to another podcast of Heal Without Harm, where we dig deeper, ask better questions, and bring real solutions to the table, especially when the system, the medical system in particular, falls short. Today's guest is someone who's changing the game for women's health from the inside out. I'm joined by Dr. Kirsten Harris, a pelvic floor specialist who brings a unique mix of clinical expertise and deep empathy to her work with women. She's not just focused on rehab, though. She's passionate about restoring confidence, dignity, and strength in the women she treats. Whether it's postpartum recovery, pelvic pain, or leaking that women have been told is just normal, she's not here just to manage symptoms. Her main goal is to help you solve the puzzle and get to the root cause. From her own personal health journey to the cutting-edge tools she's using in clinic, like dry needling, manual therapy, and whole body evaluation, you'll hear why Dr. Kirsten is quickly becoming a go-to in the space here in the Wichita, Kansas area. I can't wait for you to hear this one. Let's get dove in. Let's get dove in. Dr. Kirsten, welcome to the podcast.
Thank you.
I'm excited to get into some of these. I asked some people on the socials what they would like to know, and 2 or 3 things that we'll get to, but I don't want to dive in just yet, but I want to at least let people know what they're going to be hearing is apparently you treat the whole body, even though they may be coming in for pelvic floor specifically. Kegels are not the solve-all. They're not the only answer. Apparently there's other things you can do to help the pelvic floor. And then one big question was, what does an initial evaluation look like? We will get to those.
Okay.
Deal?
Yeah.
So tell me a little bit about your personal health journey. What have you been through? And then what made you land with pelvic floor? Like, why did that become a passion of yours?
Oof. Honestly, even going into PT school, I didn't know pelvic floor therapy was a thing. I grew up in a really small town of 400 people. So even the world of physical therapy, really, really small. But I was super athletic. So I decided either athletic training or PT was in my future. Once I got into school, I realized even just college athletes, I wanted to expand treatment to everybody of all ages. So through PT school, once I was introduced to pelvic floor therapy, I was still like, nope, I don't want to treat it. I ended up deciding to take one class because I actually had a lot of conversations with people from back in Axtell where pelvic floor therapy is really, really hard to come by. And it started kind of weighing on me pretty heavy, where I just feel like the Lord was like, hey, I gave you these skills and I gave you this brain to use it and to help heal women for it. So I didn't give up my love for working with everybody else too, but treating women's health became a big piece for women just all over the board, especially those who didn't feel like pelvic floor therapy was something that they needed in their lives.
Yeah, and I've sent patients to you, and one thing that makes me feel good is, one, I know you're extremely competent and very good at what you do, but it's nice to hear when I initially send them over, like, hey, I think this may be pelvic floor related, and I can tell they're unsure if they want to do it and kind of what all it entails. And they always leave feeling not only comfortable, heard, but also like significantly improved. I've had a couple gals that I've sent over with low back pain or hip pain or like inside of the thigh pain that may have been pelvic floor related, may not. But after they go through your care, they're much better and improved. And so with that being said, another question I was going to ask is kind of what shifted you from orthopedic to women's health, but you answered that quite well. And I'm curious, like, for the people who are listening, what is your pelvic floor? Like, let's just go super basic. Like, what does that even mean? Does everybody have one? Like
Yeah.
What is it?
Great question, because a lot of people, males in particular, don't realize that they have a pelvic floor, but every human has a pelvic floor. It's just another set of muscles that people shy away from. So your pelvis are your 2 hip bones. Everybody is very aware of your glutes and your hip flexors, all of those muscles that attach to the outside of your hip bones. But your pelvic floor is the big set of muscles. So you have 3 different layers that are actually the inside of your hip bones. So they're the bottom piece. When people talk about pelvic floor, they think that it's just those muscle groups once they're introduced to it, or they just think of Kegels, or they think of pregnancy. But your pelvic floor is an essential part of your core. Your core is a whole pop can. Your pelvic floor is the whole base of it. If you go and grab a pop can or an energy drink and you don't have the base of it, what are you going to do? Like, nothing is going to stay stable.
So you're saying like the bottom of the can would fall out, right?
Exactly.
Yeah.
Exactly.
And so what do you mean by a pop can? Excuse me. What do you mean by a pop can, and how does that relate to my core? Because I thought my core was just my abs.
Yeah. So your core, the outside of the pop can, that is your abs. So you have multiple different layers of that piece, but if you're thinking of the pop can, you have the top of the pop can, you have the bottom of it. And the bottom of it, like I said, is your pelvic floor, but the top of it is actually your diaphragm muscle. So that whole system itself, that's your entire abdomen. That's what your central stability point is for the rest of your body. So if you don't have good muscle function, if you don't have good strength, if you don't have good coordination between that whole system, that's where we start to run into dysfunctions.
And what are some of those dysfunctions that women will have, you see and work with? Like, what all can go wrong? Because going through PT school, it's like, cool, you may pee when you don't want to, or you may not be able to pee when you want to. Is that about it? Or what else is there?
No. So those are two big things.
No.
Most common question I get. Those are two big pieces into it. I do deal with leakage or urinary incontinence, which there are multiple different types of that too. But I deal with pelvic pain. So one of the big pieces that I feel like gets shied on when it comes to having conversations is about intercourse. Mm-hmm. But that's a big function of your pelvic floor. You have
and
to be
also a lot of like happiness within a relationship. And
yeah,
stuff like that.
like it's a big staple to a lot of relationships, and it can take it can have a big emotional turmoil on a relationship. And so if you have pelvic pain and you're just kind of shying away from it and dealing it, you're teaching your body that it's okay to just deal with those things, and you don't actually get to have that be a pleasant experience. Like, it takes a toll on your quality of life in general, just the same way that if you had shoulder pain and you love to lift weights, like that's taking a toll on your overall quality of life. So is your pelvic floor.
Yeah. So some different dysfunctions, urinary incontinence, meaning you can't hold it in.
Right.
Urgency, is that correct? When you pee when you don't want to?
Urgency or stress incontinence.
Okay. Which all comes back to leakage.
Yep.
What was the last one you said?
Mixed incontinence. So you can have both stress and frequency or urge.
Okay.
But you have pelvic pain. You can have prolapse issues, which I would just like to throw it out there. I cannot fix your prolapse. If you've had an organ that's dropped, I can't lift it back up. Yeah. But I can help you strengthen your pelvic floor to provide better support for it.
Okay.
Now, if it's at a certain grade, that's where, if I feel like it's gone too far, I would refer you out. But if it's not, you can be symptom-free if you have a strong enough pelvic floor, if you have good coordination in your pelvic floor too.
Okay. And then one I don't think I knew about until talking more with you or other pelvic floor PTs is even constipation can be a portion of pelvic floor dysfunction. Is that right?
Huge. It's huge.
What's going on there?
Your pelvic floor, so you have both, I'm just going to be blunt with it, you have both a vaginal and a rectal part of your pelvic floor. Mm-hmm.
You say the vaginal's clearly only women though, correct?
Right.
Just
let me throw that out there. I only treat women. So for me, vaginal and rectal, yes, the males also have a different area into it too for their anterior or their front part of their pelvic floor muscles.
Yeah.
But with the women that I treat, your third layer, it wraps around your rectum too. Okay. And so if you have a lot of tension into those muscles, it could potentially be keeping you from having a bowel movement.
Okay.
When you don't have a bowel movement, it's going to back up everything. It can lead to abdominal pain. It can lead to low back pain, referral from all of those pieces. So whether or not it's rectal work, which I can do, or vaginal work, which I also do, it's most commonly known, constipation plays a huge factor.
Okay. Gotcha. And so with that being said, why would I be, well, I guess, if I was a female being treated, why would I be having constipation secondary to this muscle spasm? Or I guess, so what leads to these muscle spasms? What are some root causes that you've seen in your experience?
There are a lot. The most common one I would say is postpartum. Just because those muscles, whether or not you have a vaginal or cesarean delivery, those muscles take a hit through the pregnancy itself. They're the bottom support system of all of your organs. So now you have a baby growing inside of it. They're taking a hit. And that's probably the biggest population that I see. But you can have other issues where it's an athletic induced dysfunction pretty much. Okay. So, with increased stress into your pelvic floor, if it doesn't tolerate it well, it can lead to a tight pelvic floor. If it's tight, when you go to either urinate or have a bowel movement, those muscles have to relax completely.
So you're actually, I feel like when I go to use the restroom, right, like I'm pushing, whether like not hard, but like I'm pushing, right, like one way or the other. It feels like I'm doing something active, but you're telling me the muscles are actually relaxing.
The muscles should actually relax. So your pelvic floor muscles. So let's say if we're talking bowel movements, your first two layers of the rectal region is your external sphincter.
Okay.
That one you have control over. Okay. So when you say you have to pass gas so bad, right? But you're in an awkward situation, you don't want to. Mm-hmm. What are you going to do? You're going to squeeze. What you're squeezing is the external sphincter. That's how you hold it in. Yeah. Your second one is the internal sphincter. That one you don't have control over. So your body naturally does it. Okay. Your brain controls that piece. Yeah. So when you go to the bathroom, things have to come out, right? Mm-hmm. Well, if you're squeezing that muscle, things are not going to come out. Okay. So some women and men run into constipation issues because they don't realize they should be relaxed.
Gotcha.
And so when you should be relaxed into it, things move out. If you're constantly squeezing or your body's naturally holding on to that tension and you don't even know it's really tight, it holds the stool in. Okay. Well, we know that if you have stool that's stuck in your intestinal tract and it's just sitting there, your body's eventually going to reabsorb the water from it. Gotcha. Especially because I feel like,
the problem.
Right, exactly. So your body will reabsorb the water. Then it's harder to pass. So there are all of these different factors that play into it. It's not just a one size fixes everything.
So are you saying when you mentioned on the internal sphincter of being like spasmed up or like tight, is that similar to like somebody who's got chronic like upper trap symptoms where they have headaches all the time and it's like they don't know it, but they're kind of staying in spasm?
Yeah. So a lot of people talk about how people carry their stress in their shoulders. They'll just say, oh my gosh, it's always tight up here and they're rubbing on their upper traps. But another area that I feel like a lot of people carry their stress is in their pelvic floor. And it could be pelvic floor, it can be abdominal region. Mm-hmm. That's a big place that people carry emotional distress. Yeah. And so it's one of those areas that's easy to just keep squeezing and you don't even know that you're holding on. Your glutes and your pelvic floor are really big.
They're just turned on like all the time.
Turned on all the time. You're standing there and you don't even realize that you have to be like, oh, wait. Let me relax my butt cheeks because I've just been squeezing them for the past 2 hours that I've been standing here.
There was one too that I noticed. I had an early 50s female. She came in with what we thought was like, well, her doctor thought was disc bulge and stuff. And she actually had one of the cleanest MRIs I've ever seen, literally ever seen. And then when she came in, it was like her entire low back on the left side. It looked like she was flexing incredibly hard. But the right side was like soft and squishy. It was actually able to turn off. Well, after we got through the initial kind of eval and everything, I was like, well, pretty much everything's locked up. So this is all muscular. You got confirmed it's not a disc bulge, yada, yada. One of the true sciatica type presentations, but I think it was sciatica induced by this insane muscle spasm. Well, it was like visit 2 or 3. I had her laying on her back, knees bent, and I was like, all right, I'm going to teach her diaphragmatic breathing. And after like 10 minutes of her getting pissed because she could not figure this out, she could figure out how to like expand her belly and like push it out and then relax and, moving back and forth. She's like, are you telling me that I have not like been breathing correctly for like 52 years? I was like, kind of, maybe, I don't know. Like this is bad though. like you're really struggling. And then I thought back and I think she's probably the third female that I have treated. And she was a more slender, petite sized female. And I think what it boiled down to between her and the 2 other gals that I had in mind is I think they always wanted to look skinny. I don't think this is wrong, by the way, at all, but it's an observation that I made. They keep their tummy pulled in.
Yep.
Right. And so it's like they don't want to have a pooch. They don't want to look like their belly out. If you ask my wife, I have no issues with it, I guess, because it's always hanging out. But I think there is I don't know if it's stigma or like perception of like always looking skinny. And I think that became so ingrained in her, like you said, like holding tension.
It's huge.
Yeah. And so like, do you feel like that it was just abdominals that she was potentially tightening up, or like what have you seen in this with abdominal keeping tight in the on position?
Yeah. So that's a great question. And honestly, I'm glad you brought up the constantly squeezing it in because it's been a huge, and whether you want to call it a stigma or whatever, just in society that females should look thin. Like that was there for so long that it's a natural instinct, especially when you're around people, to just hold everything tight. So when you're constantly sucking in your abdomen, like that's one of the cues that I give people when I'm trying to get them to engage their deep core. So your deep core muscle is your transverse abdominis, right? Okay. One of my cues, if people are really, really struggling with it, is I have them just try to suck in their stomach. Because when they suck it in, they are engaging a little bit of their transverse abdominis. Okay. But one of the big things that I teach people too is your transverse abdominis, that type of core bracing is really, really highly associated with your pelvic floor Kegel.
Okay.
So when you're sucking it in and you're drawing it in, you're probably also lifting up your pelvic floor while you're doing it, and you just may not be aware of it because a lot of people aren't necessarily aware of when their pelvic floor contracts.
Would you argue that nearly most people?
Yes, unless you've been through some form of pelvic floor therapy or different healthcare systems within pelvic floor, because you don't have to think about your pelvic floor contracting on a normal basis.
Mm-hmm.
If you are completely asymptomatic, all things pelvic floor, and it's really healthy, when you go to sneeze, it naturally contracts to the amount that it should.
Yeah.
When you go to cough, same thing. When you go to jump, same thing. When you go to lift, all of those things should naturally happen, and you shouldn't have to actively squeeze your pelvic floor.
And then when you want to pee and poop, you just go.
Right. They naturally relax too.
Yeah.
So your body should naturally make those things happen with your pelvic floor. So when you're constantly holding in your stomach to look skinny and look thin, you're probably also squeezing really tight into your pelvic floor.
So you're saying we shouldn't always be doing that?
No.
Okay.
The biggest thing that I tell women, especially when I'm doing things like workshops, is your core needs a rest break the same as everything else. A lot of the population I work with are weightlifters. So I ask them, like, okay, well, how many times do you train your quads? And it's once, maybe twice a week, right?
Mm-hmm.
Okay, well, if you're spending every waking minute holding in your core and constantly bracing your core, when does it get a rest break?
Yeah, because it's still a muscle.
Exactly.
Or a group of muscles.
Exactly.
For that matter. Gotcha. So in that respect, I know sometimes I'll get the question of like, yeah, I just don't think I engage my core enough, or like, how much should I engage my core when picking up heavy things, or do I need to engage my core when I bend over to pick up a laundry basket, or a heavy weight, or like, I think I have a weak core. What would you do with those statements when they're stated in front of you by a patient?
Well, one big thing that I like to preach is your core bracing. There are multiple different ways to brace your core.
Okay.
So your powerlifting brace is going to be very different than your CrossFit brace, than your transverse abdominis brace. So when I'm teaching you stuff here on the table, I always tell people, especially if they're into lifting heavy weights, this is not the same brace you're going to use before you go and deadlift.
Okay.
So there are different types of bracing, and you shouldn't always have to contract your core as hard as possible. The intensity of your core brace should match the intensity of your exercise. So the first thing I do when somebody's laying on my table and we're talking about core is I first ask them to brace just however they would naturally brace. I don't give them any cues, no feedback, anything. I watch them brace their core. Then I'm like, okay, why are you bracing that hard if you're just laying on a table? Or they do a kick out. Why are you bracing so hard? Your core doesn't need to be braced that hard to have the stability that it needs to keep everything going.
Interesting. So what would you say if someone was just trying to learn how to brace their core neutrally, or like with no big event, they're just trying to brace their core? What are some common cues you've noticed that you've given to people?
Probably one of my favorites is to have somebody cough. I'll have them poke the sides of their abdomen.
Okay, so on the outsides of like the six packs, what would we call like obliques, right?
Right.
Okay.
So I have people put their fingers there and I tell them to cough. They'll feel them gently brace and kind of push out laterally into your fingertips.
Okay.
That's what I would consider a fairly neutral core brace.
Just a general brace.
Just a general brace for most activities.
Gotcha. Do people need to do more abs? Like, should people be working out their abs much more than they are?
Not necessarily, but I don't want to say there are people that shouldn't increase it. There are some people who have a really weak core, especially with the population that I work with.
Yeah, if we're thinking pelvic floor,
if we're thinking pelvic floor,
that's who you treat.
So depending on the person and depending on what their symptoms are, depending on what the rest of their body is doing, I may give you specific core work. Otherwise, it may just be a, hey, let's retrain your brace while you're doing your compound lifts.
Okay, so let's get into some of the things I mentioned before. We talked about whole body assessment, and we also talked about what's a normal eval look like. So let's go ahead and meld those two together. And so someone comes in or they're listening now and they've got what they think is hip pain, back pain coming from pelvic floor. Every time they sneeze, they pee. They can't deadlift more than 100 pounds without peeing, or they're constipated, something like that. And I know, right? You're going to give me the it depends kind of answer.
Always.
But what does a normal evaluation look like? Like they call in, they get paperwork sent their way. What are some questions that they can expect on that intake paperwork? And then what can they expect in that first hour eval with you?
So the intake paperwork, it's going to have all the general orthopedic questions too.
Okay.
Because we want to know, what do you think is happening? Where are all of your areas of concern? Listing out all of those things. What hurts it? What makes it feel better? What's your activity style? We want all of that as a background information. In the pelvic floor specific ones, it's going to have that plus a questionnaire that asks specific stuff about incontinence. And then it's going to ask specific things about your bowel function. So it'll ask stuff about constipation, or it'll ask things about feeling heaviness. That's a big one that people don't know. It can be a pelvic floor dysfunction, is feeling heaviness in that region. So it'll ask about all of those things. It'll have some prolapse specific questions like, do you have to push around your vaginal or rectal region just to have a bowel movement or to be able to urinate? So it's going to go into some of those specifics, and then it just has a grading scale. Does it happen? How much does it affect your quality of life? That just gives me a good idea on, okay, these are things that they're dealing with. So if I have women that come in that say, no, my pelvic floor is fine, I don't leak, but then they go to that questionnaire and there's yeses on some of the things for bowel function, or there's yeses on heaviness or discomfort in the region, that tells me, okay, pelvic floor could be a piece that's added into this.
You're going to follow up on that for sure.
Exactly.
Okay. So they get that filled out and they come in. What does the hour look like with you?
So like you said, my answer is always going to be it depends.
Mm-hmm.
But the majority of the time, if women are comfortable enough with it, I do internal work.
Okay.
Like I mentioned, I think briefly before, I do vaginal and rectal internal. I almost always start with vaginal unless there's some big key factor, but that's rarely ever the case.
Yeah.
So I typically start with vaginal. You come in, we start with just talking.
Mm-hmm.
I want you to tell me in your own words, what are you experiencing? How is this affecting you? All of the quality of life stuff, so I get an idea on what is most important to you to fix first. And then we go into some of the testing areas next. So typically, I'll look at your trunk motion. Then I will get out my pelvic model. I will educate you on the different muscles, on the different functions. We'll talk about referral pain patterns. If you're not convinced it's your pelvic floor, but you've had this nagging back or hip pain that just hasn't gone away, even with PT addressing those areas. Mm-hmm. Then if they're open to it, and I will never force somebody to do internal work. It is always that day getting consent each time, even getting consent each step along the way. We go into the internal assessment piece. That, I mean, I get sheets out on the table. There's a chuck pad. You have a sheet to cover yourself. Then you essentially get undressed from your waist down. I'm out of the room at this point. You lay on the table on your back. You use the top sheet, cover yourself, and then I knock and I come back in. I don't use any type of tools or speculums, anything like that. I wear gloves.
Speculum, the tongue-looking thing.
It is. Yeah. If you've had a pap smear, well, woman exam, you know what that is. Yeah. It can be uncomfortable. Like, exactly. Yeah. But I just use gloves. I use a lubricant, which is almost always water-based. And then I go through each of those 3 muscle layers. So I'm always asking for consent through each of those layers, because you never know the emotional response somebody is going to have from an internal pelvic exam.
And sometimes they don't either, right?
They don't.
That's what I've heard. Like sometimes it's like stuff gets brought up, right?
Yeah.
Like this is when we go to the emotional and
I've had a couple of clients. One of them, we had to stop because she just felt triggered with something, and she was like, "I think I need a break." That's all you have to say. I am immediately out. We can move to something else treatment wise. I've had another woman who she just started hysterically laughing. She had no idea why, and she even looked at me and was like, "I don't really know what's happening." So we took a break. And we just kind of chatted about a few things. We ended up resuming internal work that session. But during that time, she just thought it was the most funny thing of what was going on. And she didn't know why she couldn't control it. But those are just some of the responses that can happen. And so we go through first layer. I'm assessing all of the muscles in that area. What's normal to feel is just a deep pressure sensation. But if you have tension, you might feel a stinging sensation. You might feel referral pain up towards the clitoris. You might feel a really deep aching sensation. And then after I go through looking for that tension, I will ask for permission, go into second layer, do the same thing. And then I'll ask for permission, go to the third layer, do the same thing. Each step of those ways, I'm asking you, what are you feeling? I'm taking note of what I'm feeling. Once we get through the muscle tension or lack of tension piece, then I'm assessing your Kegel. So this is the most popular area that women know is a Kegel. And some women are really great. They know, they have the coordination. They know what they're doing. They're squeezing their pelvic floor and they're lifting it. Other women will think they're Kegling, but they might actually be bearing down. So they're trying to push my finger out. So this is where it gets into the point of, one, do you have the coordination to know what a Kegel is? Are you holding tension? Because if you are, you're probably not going to be that strong. It's like taking your bicep. If it's already holding tension and your elbow's bent, you have no room for it to move.
Will you also notice that when trying to assess the layers, it's harder to get in if they're stuck in spasm? Or will you just feel like the tissue is tighter, like a top band, like I would on your upper trap when I squeeze it?
So very, very dependent.
Okay, gotcha. All over the place.
Every female, there's not going to be a single female who's going to walk in with the same pelvic floor.
Yeah, that's fair.
And so some women, if it is really, really small diameter-wise, we may only get to the first or second layer. And I would never force into the third until those areas are relaxed. If there's more room for it and then we get to it, it will just feel like a top band. Okay. And then I can move into the second layer and take pressure off of the first and kind of go from there.
Gotcha.
But we're looking at just your strength. We're looking at your coordination, which involve quick flicks. So can you contract and then can you relax?
Gotcha.
And then I look into endurance too. So can you hold that strong contraction for an extended period of time?
How long is that? 5 seconds?
10 seconds is the typical goal that I have people go into. And then the quick flicks is 5 quick flicks. Your ultimate goal is doing it in 5 seconds, but I have a lot of women who can't.
Okay. So it sounds like you mentioned sometimes it's a coordination issue. They can't turn it on and off like they should. And then there may be a strength issue or spasms, like a spasmatic issue.
Right.
So it sounds like it ranges from, hey, things are really tight and I can't get them to relax. I don't know how to relax. I don't even realize I'm tightening them. Some people are very, very weak. So they may be coordinated where they can get it to go, but it's like there's not much heavy contraction there.
Right.
What are some like, how do I say this? So you find certain things. What are like examples of exercises that you end up leaving gals with? Because you say Kegels aren't always the answer, which of course, that's like saying squats don't solve everything for knee pain or something, you know?
Right.
So what are some different variations of exercise that you may leave a female with? Let's go in the department of leakage and or weakness, if that's kind of the category they're falling under. What exercises are they potentially doing?
Yeah. So when it comes to leaking, that leakage could be because they are so tight that their pelvic floor cannot respond and react the way that it naturally should, like we had talked about. Or it could be they have no strength in it. There's no tension, but they can't contract it. So some of the exercises, if it's tension, if that's the issue with it, is going into positions like child's pose or happy baby or really deep yoga squat. But the basis of almost all of the pelvic floor things initially are going to be diaphragm breathing.
Okay.
So that if there's one, if you even want to call it an exercise or skill that every one of my clients is probably going to go through to at least prove to me that you can do it, or two, because it's going to be the basic foundation before all of our exercises, is the diaphragm breath. Because if we go back to that pop can, when you diaphragm breathe, your diaphragm pushes down.
So the top of the pop can
the top of the pop can pushes down. It's like popping the pop can into the freezer and it starts to expand. Well, what happens? You go in there and the bottom of it's popped out. Well, that's what happens when you diaphragm breathe is diaphragm presses down, your core, the abdominal region, those expand out and your pelvic floor also expands out.
Okay. And that's correct.
That's correct diaphragm breathing. Okay. Diaphragm breathing is not your everyday breath work, but it's what I'm going to use in positions like happy baby and child's pose to get movement happening in your pelvic floor to provide that stretch and then come back to rest, stretch and then come back to rest.
So even though child's pose, which is, for those who don't know, hands and knees, and then you essentially sit your butt back onto your heels. So arms end up going overhead. So arms are overhead. You're sitting back onto your heels, butt is kind of resting on your heels. Even as a PT, I think, like, what is that doing for the pelvic floor? Because in my eyes, all you're doing is moving stuff externally, right? You're moving externally compared to the pelvis. You're moving your hip joint.
Right.
So what is that doing? Let's go into this for a second. What is that doing to the pelvic floor?
So when you're pulling into that external rotation, so there are some hip muscles, like your obturator and turnus, things like that. They do go into the pelvis.
Okay, so like the lower butt cheek muscles.
The lower butt cheek muscles. Exactly. So you are putting a stretch into those muscles. And then if you're just sitting there, you're probably not getting a great pelvic floor stretch. But when you add the diaphragm breathing piece, that's where you get the movement of your pelvic floor.
Okay, that's when you would intensify the stretch.
Yes, that's how you intensify and actually get pelvic floor specific rather than just hip.
Okay, that makes sense. So what makes a good diaphragmatic breath then? Where could you coach an example just with words?
You're right.
Essentially.
So
also, if you decide to try this, please don't do it while driving.
Please don't. It'll take a lot of coordination. I think
they're going to be like zoning out, focusing, and then they just steer off the road.
That's the biggest piece of pelvic floor therapy is initially my clients get so frustrated because it's more of a mental game than it is physical.
Especially if you're treating some 40, 50, 60-year-old lady. Like,
yeah. This
we're not
is
used
years.
to learning stuff,
This is years
yeah.
of retraining it. So when you diaphragm breathe, I always cue, take a big inhale through your nose if possible. If you cannot, you can breathe through your mouth, but I always cue in through the nose, out through the mouth. But when you inhale through your nose, I make somebody put a hand on their chest, a hand on their lower abdomen. Your hand on your lower abdomen should be what's rising up towards the ceiling. I never have people push.
Assuming we're laying on our back.
Right, you're laying on your back. Inhale through your nose, belly expands out 360.
Forward, backwards, sides.
Forwards, backwards, sides. The whole thing is expanding out. And then I tell them to picture your pelvic floor. Say there's a balloon sitting in your pelvic floor region, which I have my model out so they know what I'm talking about at that point.
You blow up a balloon.
You blow up a balloon and it expands out. Yeah. I don't blow up a balloon in my sessions, but maybe I should. But when you're inhaling, belly and pelvic floor both get a blossom out or expand out. You're never pushing it out. So there's no bearing down. There's no shoving your abdominal region out. It's all a natural increasing out, and then you exhale through your mouth and it just falls back to rest. None of this is contracting and squeezing anything. None of it's excessive pushing. It's all small, natural movements.
I like this. This is good. Unfortunately, we're getting low on time, and so we'll probably have a part 2 in the future on this. But I think what I would like to finish with is myths, because I think what I've learned about PT for myself, in regards of like knees over toes, or you should always do this or never do that. Like, what are the most annoying myths that like continue to stay alive in the world of social media, or just ladies talking to each other, or misconceptions about stuff that you've noticed around pelvic floor? What are some of those?
The first one we already kind of addressed, that Kegels fix everything. They don't.
Mm-hmm. And could potentially make things worse?
They could make things worse. If you are holding tension and you're like, oh, well, pelvic floor therapy is not going to be good for me because I've tried Kegling and it only made it worse.
Gotcha.
Like, that's not the answer. The other one is that any of these dysfunctions are normal. None of this is normal. That's like saying any pain you're experiencing, oh, it's just normal.
Mm-hmm.
No, that's maybe your current state. So maybe it's what you've gotten used to as your normal. They're very, very common, not normal.
I argue sometimes it is normal because everybody's having this pain, but it shouldn't happen.
No. Get normal out of the vocabulary.
Get fixed, ultimately. Okay, gotcha. And so some other like quick questions that I would like to ask. How do people know when to come ask for help?
If it's something that's lasting longer than a couple of weeks, then seek help.
Okay. And then should every female after birth come in for an exam?
In my opinion, yes.
Okay.
After that 6-week, or if it's a C-section, potentially a little bit longer, after that original healing process, I think it would always be a good idea to at least get an assessment. Some women heal great. Their pelvic floor recovers super well. So we'll assess it, and then I'll tell you, hey, like, things are moving on the right track. Cool. Go on, live your life. If in a few months you feel like you're at a standstill where things are not continuing to improve and get better, come back.
So even if they come in for an eval, that you may not even recommend a plan of care because they may be doing fine.
100%.
What is a normal plan of care? Like, let's take, standard deviations, blah, 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 bell curve. Average gal walks in here. They do need your help. There are dysfunctions going on. They've been having it for, we'll say, 3 years. Like, how long are you needing to see them? How long do you work with them? How often? What does that in general look like?
I typically tell people a 12-week process that has a very, very high chance of changing.
Okay.
Especially if you're trying to get back to anything that is impact related. So whether it's really heavy lifting, whether it's jumping, running, things like that, it might take a little bit longer.
Okay. And does duration of symptoms matter as well?
Yes.
Okay, gotcha. And so most of the time you're seeing them for 12 weeks. Are you seeing them once, twice, 3 times weekly? What does that look like?
Typically, it's once a week, and that's probably through the whole 12-week process. If it becomes more of an impact thing, longer term changes after that, it's going to extend out to maybe once every couple of weeks or once every month to finish out the duration of treatment.
I think a question that a lot of people have that I always wrestle with as a PT, because I know it's coming for most people, is why do you need to see them once a week for all 12 weeks? Like, why? Like, I think why is just the main answer.
Yeah. So because I do internal work, manual therapy, if it's needed, is pretty heavily relied on during the initial phases of treatment. But I do recommend sometimes that people get different tools like wands if we're addressing things like that, or dilators if we're addressing things like that, which means they don't typically need me.
So they're attempting to do the manual on their own.
Right.
Correct?
They're attempting to do some of it at home. One of the biggest pieces that I even get feedback from my clients that want to try to go out 2 weeks at a time is having the consistency and somebody to hold them accountable during it.
So keeping them doing their things.
This can be a huge process. So not only are you getting weekly check-ins to say, okay, how is everything doing? But this is also a piece that you're making life-changing quality of life pieces, whether they're small or big. For pelvic floor women, most of them are huge wins, even if it's something as simple as, I just belly laughed for the first time in 10 years with my daughters because we did something stupid and I did not pee my pants and I didn't even have to think about it. Like, how common is that for women to not be able to laugh like that without having to go change?
Yeah.
Like, that should not be the case, but that is such an improvement in quality of life that they want to share it with somebody. And that's not the typical post on your Instagram story, I didn't pee my pants when I laughed this time. Like, nobody wants to say those things for the most part. But
coming to you, they're going to celebrate it like crazy.
Coming to me, they celebrate like crazy. We are cheering in the room, all of the things with it. I get email after email of those things just because they want to share it with somebody that it's a big win for them.
For sure.
So I'd say that's probably one of the biggest pieces.
Cool. That's awesome. And so moving forward from here, people are listening and they're like, oh my gosh, maybe I should do something about this. What would you recommend as the next step? How can they contact you? How can they contact the clinic? What would you recommend from here?
I mean, you guys can always text in or call our clinic at Natural Wellness. You can visit our website and you can actually book an eval yourself. You can also reach out to just me personally at my email address at work. So it's Kirsten at naturalwellnessphysiotherapy.com. Any of those routes are great to reach out, and all you have to do is voice your concern. You can share what you want or what you don't want yet, and we can get you on the schedule and have that conversation.
Perfect. And for all of you listening, since she works here at Natural Wellness Physiotherapy, anybody listening right now that wants to reach out, I'll have links down in the podcast description. And if anybody wants to come in because they're needing help, the evaluation will be half off. That'll be indefinite. So if you've heard this podcast and you're wanting to come in, you will get half off the evaluation to get those answers. If you're still waiting to dip your toe in the water, we do offer free consults. So you can just come in and talk to Kirsten for 30 minutes completely for free, because I know from the ones that I've sent over to you, people are very hesitant. And honestly, after watching my wife go through a couple pregnancies and all the doctor's visits, it's very personal. And I totally understand, especially if there's been any trauma in the past, because honestly, trauma is potentially the reason that you're having the dysfunction. So I would totally understand if you wanted to just come in and get to know Kirsten first before you guys take any other steps. The final question I meant to ask earlier, can you get results without internal work? That was the other question I wanted to ask.
Depending on the situation, potentially.
Okay.
If somebody is absolutely against it, we start all external, because your pelvic floor is a part of your body. So we can start treating all things external body-wise, and your pelvic floor might catch up.
Cool.
I can't say 100% all the time, but there is a chance that it could.
Okay. That sounds good. And so, like I said, I'll have all the links down below, and we'll continue to post stuff on our Instagram, mine in particular, at the Doc Dir, and then also at Natural Wellness Physio on Instagram. We will have those out there. Kirsten, is there any other parting thoughts that you want to put out there before we wrap up?
Not that I can think of.
Cool. Pain's not normal. I'll just say it for there.
Common, not normal.
Common, but not normal. There you go. Let's make it less common. How about that? So hopefully today on the podcast, you learned a little bit more how to heal without harm. And thank you, Dr. Kirsten, for coming in.
Yeah, thanks for having me.